and just load it onto, and I'll take care of doing it probably tomorrow when I got good internet connection. I'll load it up. Dennis, how are you? It was so good to meet you last week. You there, Dennis?
Yeah, I'm here, Rick. I just got to take my phone off mute, and the feeling is mutual, and the pleasure is all mine.
Well, I sent you a note afterwards on your email. I don't know if you got it.
Yes, I did.
Okay, great. Good. I just wanted to be sure. So, Jake, I'm not, I think Bill's going to join us. I'm still in the airport in at JFK, so I'm probably going to stay here overnight because this has been a journey from hell.
So you've been sitting there for 5 hours.
So I can't.
6 hours.
Oh, I've been sitting here. I've been here since 10 o'clock.
Oh my goodness. Jeez.
So, and when I spoke to you, I was actually on the flight, and then they got us off the flight, and then I just made a decision that I was better off doing this meeting and knowing the logistics just by staying here and getting the flight tomorrow, and there were some other factors too.
Right.
So I cannot, since I can't get on to go-to meeting, I cannot see who's on the meeting, so I'm going to rely on you and Bill to let me know who's there, and you're going to have to do the roll calls and stuff, okay?
Okay. So far we have Bill Franklin, Dennis Correa, Don Price, Eric Bookbinder, you, and me. And we have two individuals on the telephone who, would you care to identify yourselves on the telephone?
Neville Black from Australia.
Neville Black? Did you say?
Yep.
Oh, welcome. That's
yeah,
nice.
that's right.
How are you, Neville? Gosh, that's a surprise. How you doing, man? Are you going to be at PCRI this year?
Yeah, definitely. Yeah.
Okay, well, we're expecting you and Jim Marshall. If we can get this reception together, we're expecting you and Jim Marshall to hold up the Australian flag at the reception. You know that, don't you?
Oh, well, yeah, Jim's coming too. Yeah.
Good.
Rick, you got my email?
This is that?
Yeah, this is Bill. I sent you an email. I signed up and everything. I actually got a flight reservation now. So.
Oh, this is Bill? Hey,
yeah.
Bill, I sort of recognized your voice. Great. I'm glad you got the flight reservation, and yes, I got your email, and yes, we're going to be anxious to see you. I mean, I've got a bunch of work to do this week, and hopefully we'll get everybody together, and we'll get everybody on the same page, and we'll get this reception organized before the end of the month as well. That's what I'm hoping for.
Let me know if there's something I can do to help.
I absolutely will. The big thing that you're going to be doing to help is that I really appreciate you helping me out, co-moderating the other call. That'll be really helpful. So I appreciate it. Thank you so much. Okay, so we have
one other person on the telephone who has not identified.
Jim Harrington.
Hello.
Jim Harrington.
Jim.
Hi, Jim. How you doing tonight?
Jim Harrington.
Oh, I'm doing okay.
Good.
The elusive Jim Harrington.
Well, just missed a couple. Yeah, well,
I'm glad.
Back. Yeah,
well,
thank
I'm
you.
glad you're back. We want to check in with you because your trial keeps coming up. I've got a lot of people asking me about.
Yeah, well, I can tell you about it. Sure.
Good. We will definitely. Listen, you probably didn't hear, but I'm not too far from you. I'm sitting in.
Yeah, you're stuck at Kennedy. Yeah, well, yeah. I mean, I've been to Kennedy a lot of times. It's a terrible airport to get to. Once you get there, it's not so bad. But hopefully, you'll find some good lodging for the night if you have to stay overnight.
Well, I'm probably just sleep in a chair here because by the time I get out of here, here and then get back for an early flight, it's not worth it. And there's food here. You know, one of the reasons I didn't I didn't want to deal with lodging in Burlington, Vermont was because I really would have to find it. I didn't know if there'd be food there and getting there, and so I thought, better the devil I know than the devil I don't know. I can sleep anywhere, so I'm lucky.
Well, if you can sleep in a chair, that's good. Yeah, good for you.
Okay.
Well, so this is Don Price. I have spent the night at Kennedy on the floor, the best place. Very nice.
So, do you have a T-shirt? I think, Don, we need T-shirts. I spent the night at JFK. What do you think?
Yeah, I think that's kind of cool. You'll create a thing. You could probably sell 1 million of them, actually.
There you go. But wait a minute, not if you've got to be an ANCAN participant as well. So, you know, it takes more than just spending the night. But yeah, you're right. Actually, you're right. They should have them in the gift shop here. I spent the night at JFK. They probably sell a lot of them. I'll suggest it to them when the meeting's over. How about that? Okay, so, Jake, who do we have on the call at this point?
Okay, we have me, Bill Franklin. He said he had to step away for about 5 minutes, but he'll be back. Dennis Correa.
Okay.
Don Price.
Right.
Eric Bookbinder.
Right.
Jim Harrington.
Right.
Neville Black from Australia.
Right.
Paul Frieda.
Yep.
Rick Davis, and Bill Burhan's just joined us. He's still logging on. It'll take him a minute or two to get sound. So far, it's a small group.
Okay. Yes, but it'll grow. What do we have? We have 1, 2, 3. Oh, and Bill, and somebody else just joined.
Yeah.
So, who is that?
That was Bill.
That was Bill. I'm sorry. That's right.
Oh, that was Bill. Okay. Okay, so we got Bill, Paul. Okay. Well, give me two more seconds. I'm going to try and at least pull up my database. So, excuse me, if I can do that, it'll make life a little bit easier. And then we'll get started. Kind of interesting doing this blind without actually seeing who's in the meeting. So it looks like this database is not going to come up that easily. The problem being in the airport is that the internet is just very sporadic, and I'm going to apologize in advance if you just keep hearing the background announcements. I thought of asking them to keep quiet whilst we had our meeting, but I didn't think I'd get much satisfaction if I did that. We are where we are. Okay, so let me run down the list here. Let's start with Jake. Jake, do you have anything you'd like to talk about tonight?
No, not tonight, Rick.
No. Is Bill Franklin back with us? No. I'm sure he will be. Dennis, Korea, anything for you tonight?
Just listening in tonight.
Okay. Don Price, how about you?
I have, since there's not much going on tonight, I have a very minor issue that I can talk about.
Okay. All right. Yeah. I mean, I think we're gonna have time. Eric Bookbinder, any updates from you or any questions from you for tonight?
Sure, I can add some.
Good. Okay. Neville, you want to give us a little report from down under?
Oh, well, it's nice and sunny here today anyway, I can tell you that much where I am, just west of Brisbane. I've been on Eligard for a bit over 6.5 years.
Hold on a second, Neville, because we'll come back to you for sure.
Yeah.
I just want to check in, but yes, definitely. In fact, we'll probably start with you because I can't remember if you've actually been on the call before, but if you haven't, then we should definitely start with you. Jim Harrington, I know we're going to be talking to you because we want to hear more about your Listeria.
I talk about pembrolizumab and Listeria trial. Yes, I can talk about that.
Right. Paul Frieder, anything for you?
Yeah, I have a question or two. Yeah.
Good. Bill, how about yourself? Anything for you?
No, I don't think so.
Did you say no?
No, that's right.
Okay, I'm barely hearing you.
Oh, boy.
You were really good to begin with, but now we're hardly hearing you. And
No problem.
have I covered everybody, or is there anyone else new? Okay.
Rick, this is Bill Franklin again. I stepped away. I'm back.
Oh, you're back. Bill, anything for you tonight to talk about?
I got one question. We don't have to spend too much time on it, but I'll ask something.
That's okay. We're gonna have enough time, so we'll be able to do that. So let's start with Neville. Neville, I don't think you've been on the call before.
I joined it once when you had the guy on. We're talking about testosterone needles in the bum. You know, but there was a fair few on that day, so I never even got to mention my name or anything. So yeah.
Okay. Well, why don't we, let's treat you like you haven't been on the call before, and tell the guys a little bit about your history and where you are, and what brings you to the call. The floor is yours.
Thank you. No, I was diagnosed in 2009. I had a radical prostatectomy then in April 2009. Prostate cancer returned about 3 months later. They waited 2 years before they put me on Eligard and then wanted to take me off it after a few weeks and after a couple of injections, and I decided to stay on it. So I've been on Eligard, and my testosterone's really, really undetectable, and my PSA is undetectable for being that way now for 6.5 years.
Mm-hmm.
What is your Gleason score?
Beg your pardon?
What is your Gleason score?
My Gleason score was 8.
Wow.
4 plus 4. That's. Yeah. I assume that was a 4 plus 4 curve. Is that right, Neville? And
yeah, that's exactly right. Yeah.
And was your post-pathology biopsy clean, or because you say that it came back pretty quickly? How quickly did the PSA rise? And did your
everything come back clear. The pathology come back clear after the radical prostatectomy. I didn't get a Gleason score from that pathology. The Gleason score I had was from 6 weeks before I had the operation. But
right.
But I had the operation in April, and then the June result was fine. But then in September it had started to rise. So it wasn't very long before it started to rise.
And when you say it started to rise, what sort of level did it get to before you had that first Eligard shot?
8.5.
Oh, really? So it was going up pretty quickly.
It was now because it started at really, really low numbers. It was doubling every 3 months.
Okay. And how long was it? How long was it before you? You say it was 2 years until you did your first Eligard shot after your radical prostatectomy?
Yeah, they just kept watching the PSA rise and rise and rise and rise, and after at the 2 year mark, the oncologist I'd been seeing wasn't there that day, and they asked me if I would be happy to see another one, and I said, yeah, definitely be happy to see another one, and the oncologist I saw that day, she was going to have me on Zoladex before, that same day, but not that same day, but she's got to have Cogidex first, of course, but I said no, I'd prefer to have Eligard if you don't mind. And she said, yeah, no, that'll be fine. And that's how it went. And I said that because Mark Stoltzfus was in the Gold Coast at a conference PCFA had down the Gold Coast a couple of years before. And someone asked him what the hormone therapy, ADT hormone therapy would he have, and he said Eligard. And I just remembered that, so I just said I'd have Eligard because most guys in Australia seem to be on Zoladex.
On Zoladex, Yeah, I'm not sure that there's a huge difference between Zoladex and Eligard. I mean, it seems to me that some guys prefer one, some guys prefer the other, some guys respond better to one, some guys respond better to the other. It's really hard to tell.
I'd agree with that. Yeah. I don't have a problem with that statement.
I mean, clearly there's a very big difference with respect to, say, Phomadon, which works in a completely different way. But but some people find that even just going from Lutron to Zoladex to Trelstar to Eligard, that they find a little bit of difference. I've never fully understood the reason why. Maybe one of these days somebody will explain it to me. So let me ask you a question, though. And I'm sure some of the other guys are interested to hear the answer to this one too, which is why why you didn't do any follow-up radiation, or you didn't mention it, and B, why you've decided to stay full-time on the Eligard and not try intermittent therapy.
Well, because I had a fair bit of problem after my radical prostatectomy, and I was in hospital for 3 weeks, and there was guys having an operation a week later than me, and by the same surgeon, and they were going home before I got out of hospital, and I didn't really feel like lining up for, and I had an incontinence problem at the time, and I didn't really feel like lining up for radiation after the operation that I had, and the side effects and the problems that I had after the operation. And that was my full intention initially. If it come back afterwards, I'd have the operation, radical prostatectomy, and then I would be able to have radiation. But because of the problems I had, I wasn't even offered it, and I didn't even ask for it, so I didn't. And in hindsight, I still wouldn't have had it, even knowing what I know today. And as for staying on it continuously rather than intermittent, I was really concerned because they watched it grow so quickly. When they wanted to take me off 6 months after I started, and I thought, well, if they take me off this, I might have as much trouble getting back on it again as what I had getting on it in the first place. So, and I think at the time there was a report out that men that stayed on continuously was very, very marginal. Some study that you might live slightly longer if you stayed on it continuously rather than intermittent. So, and I don't get some of the guys get really, really bad hot flashes and that sort of thing, and I don't suffer from them very badly at all. So I was able to put up with the side effects a lot better than some other guys. So that was why I stayed on it continuously. Let me throw it open. Yes, go ahead, please. Some guys think I'm nuts staying on it continuously, but I have a needle actually every 28 days. So I do. Now, I did have a situation once where the doctor was going to give it to me. The Eligard's a 2-part thing and has to be mixed before you get the needle and the injection. And I had a doctor one day didn't mix it. So I said to him as he was about to jab me with the needle, did you mix that? And he said, no, has it got to be mixed? So that was a bit disconcerting. I wasn't aware that the Eligard. I mean, I don't think I've ever seen them even load the Lupron shots, so I don't exactly know how they come together. But I wasn't aware the Eligard has to be mixed. It's 2 substances, or is that right? Yeah. Well, there's 2 syringes. One's got a powder in it, and one's got a liquid in it, and they have to be. It has to be kept in the fridge and on the morning of the injection, you take it out of the fridge and bring it to room temperature before it's mixed, and it has to be mixed for about 30 seconds, 40 seconds or something like that, and it slightly changes its colour slightly, and then it has to be injected. So it does, yeah.
So let me throw it open to the guys. Oh, I do have one other question. What made you come on today? I mean, it's good to hear your voice. I mean, people should know that we met Neville last year. A whole bunch of us went out to dinner at the PCRI conference. We had a great Greek meal, and Neville was there. Trying to think,
it was a great meal.
It was, wasn't it? We enjoyed ourselves. And who was sitting with you? Somebody, I'm trying to think.
Peter
was sitting with Peter. That's right. Peter was sitting with you. Peter's currently in transit somewhere. I kind of half expected to see him walking by me here in JFK.
No, well, the reason why I saw Rick's email the other day, and it said, if you're coming to the PCRI conference, let us know. I thought, well, this is a really good way to let you know I'm coming. And Jim's coming.
That's lovely. That's lovely. And we look forward to you. And, of course, the highlight of this year's PCRI conference, gents, is going to be John Teisberg demonstrating the life-size model of the Manjung project that some of you may have actually seen the animation, the cartoon. It's a lot of fun, and John's built a full-size model of that. We're shipping it out to Los Angeles, and he's going to be demonstrating it. With a bit of luck, we'll get Moyad involved. I'm hoping. I don't know for sure, but we're going to try and get Moyad involved. So let me throw it open to the guys. If anybody would like to ask you any questions about treatment in Australia or the decisions that you made or anything else. Anybody have any questions for Neville? No? Oh, come on, guys.
I'll put them all to sleep.
Yeah. Are we still there? Anybody there? All right.
No, I have a question. Neville, are you doing any bone strengthening, like Zometa or what's the other one? I can't think of it, Rick. For bone strengthening.
Pharmagon. Exgiva.
Exgiva, yeah.
No. I have a bone density test every couple of years, and my bones are pretty good actually. So yeah.
Okay.
I'm not on Exgiva. Don't need to be on Exgiva or anything.
Well, good for you.
Okay. Are you following any diet or exercise routine as well with your
exercise? Exercise I try to avoid, unfortunately, but sooner or later I'm probably going to have to get into that.
Yeah.
I do try to do the Mediterranean diet type thing, you know, as much as I can, sort of thing. Yeah. I don't eat very much red meat anymore, or bacon, or ham, or that sort of thing, and nuts and salads and fish and all that sort of thing.
Well, good.
Snuffy Myers has talked about all that heaps of times, and Mark Moyad, yeah.
Right. Who else? Somebody else said that they wanted to say something. Who was that?
Yeah, this is Bill.
Hi, Bill. Go ahead.
Neville, you said that you personally don't experience too many side effects on Eligard, or, I mean, it's the same, it has the same effect on lowering testosterone as any of the other luteinizing compounds, right? So.
Yeah, that's exactly right. My testosterone in Australia, we use a slightly different measurement to you guys over there, but mine's in Australian terms of 0.5, whatever it is, and that's as low as they can read in Australia. So, yeah, and it stays at that. If I have a 3-monthly Eligard needle, which is, you can have a 3-monthly needle or you can have a 6-monthly one. The 3-monthly one, the testosterone just moves around a little tiny bit. It's still not within worrying zone or anything like that. But it went for, I'd elected to have it every 28 days, and that seems to just keep it really, really, really stable. And that was why I went to the 28 days. So it is, yeah.
Okay. Well,
Rick, can you hear me?
go ahead, Bill. We can barely hear you, though. Can you speak up a little bit?
Yeah, I'm almost shouting. It's not any better?
Are you there? Is it just me, or is it everybody?
I hear him. He's really, really low, but I hear him.
Okay.
I hear him.
I'm working on, but maybe I can at least ask a question before I go back to work on it. So Neville, I'm curious.
Hey, Bill.
You've been
hello.
Can you hear me?
Yes, I can, yeah.
Okay.
Yeah.
2009 with a Gleason 8, and I'm just making sure that I have your story right. And you had a prostatectomy, and then subsequently went on Eligard. And so, did you tell us where you're at now in terms of your PSA, and how well has that been working? I'm curious because that's a long time.
Yeah, you had the story right, Bill. And I've been on Eligard since April 2011, and my PSA is still undetectable.
That's amazing. That's great.
Yeah, it's amazing. With a Gleason 8, too.
Yeah. Yeah, I was curious what you did that was right. But,
well, I did change my diet, and I was 85 kgs when I had my operation, and I dropped, and diet does have to play a part, and I did change my diet after the operation and when I went on Eligard, and I dropped down to 75. I have crept back up to 80 kgs at the moment, but I do like food fairly well, so unfortunately, but I haven't been doing any exercises, but I might have to do some exercise. But I'm still fairly active. I'm just about I'll be 71 by the time the conference comes round, so I will. And yeah, I'm fairly active. We've got units and that would look after and do a fair bit of work. So I do get some exercise with my job and that sort of thing. It's not as if I'm lie down and watch TV all day.
Okay, so you're still working at 71. Wow.
Yeah. I've always been self-employed, so yeah, and I enjoy work.
Yeah. Okay. Well, this is all. It sounds great. I congratulate you on making it this long successfully. It's really remarkable.
Yeah, that really is. Bill, it looks like Rick has dropped off. Would you mind picking up the slack for a few minutes till he gets back on?
Sure. That would be fine. I have no idea who's on the call, though.
Oh, I'm sorry. Jake Hannum, you, Bill Franklin, Dennis Correa, Don Price, Eric Bookbinder, Jim Harrington, Neville Black, that's the man you were just talking to, and Paul Frieda. And we do have one other additional caller on the telephone if he'd like to identify himself.
Jay Curran.
Oh, hi, Jay.
Hi.
Okay, so
we did have Rick, obviously, but he dropped off. I'm not sure what happened to him.
So I guess what I also don't know is who else had something to talk about. So perhaps whoever did have something to talk about could identify themselves and let us know what's up.
I think Don had
Jay Curran.
What's it? Just tell us why you indicated that you had things to talk about and what they were. Unfortunately, I can't point to individuals in that section. Yeah.
I think Paul said he wanted to talk. Jim Harrington wanted to talk. I don't know about Jay because he just joined us. Don Price wanted to talk. And Bill Franklin.
Okay, so Paul, why don't we go with you next?
Who?
Paul?
Okay, yeah. I just been reading about, I mentioned in the last last time we were together about the ketogenic diet. Basically, the idea is that cancer feeds off glucose, and if you can get your body to run off fat rather than glucose, the cancer cells will be starved. I wonder if there's anybody has any information on that, or is that just another snake oil salesman pitch?
So were you in on the call back maybe 6 months ago when we discussed this? And,
no, I guess not. I don't remember a call about the ketogenic diet. No. Okay,
so this is something that I know a little bit about as I'm a cancer scientist, and one of the other callers said just what you did, that they had become interested in the ketogenic diet and wondered what everyone thought. And I told them that I thought it was snake oil, probably, but that I would look into it. And then after the call was finished, I looked into it, and the week's following call, I told these guys that, in fact, there seemed to be quite a bit. There is some, there's some reason to think that it does work. Certainly glucose is something that is, really problematical for cancer scientists because tumors become addicted to it. And so the less that you can consume, the better off you are. And when I did some research into this, and I'm looking into the primary literature, I found a number of studies that showed that it really did have a significant impact on the outcome of some patients. So my recommendation would be to try it, but not before talking to your doctor to make sure that it's appropriate for you. Right. Is there anyone else on tonight that might be able to add to that?
So this is Don Price.
Okay.
And I am not an expert. So, sometimes I'm always a little nervous because you guys are a lot more knowledgeable than I am. But I would have said that prostate cancer is different from most other cancers and doesn't react to glucose in the bloodstream. But what it does react to is insulin in the bloodstream and can manufacture testosterone out of insulin. So for prostate cancer, what you're trying to do is to keep insulin as low as possible, which of course means essentially a low glycemic index kind of diet. So it could have the same effect being on a ketogenic diet, but the idea is not so much to reduce glucose as much as it is not to have an insulin reaction.
Yeah, you're absolutely right. I wasn't prepared to go that deep into it, but that is exactly the mechanism by which it's supposed to, these diets are supposed to work. For some reason, prostate cancers are quite different from other cancers in that they're not completely different in their glucose addiction. Glucose there is still a propensity for glucose to promote growth, but not nearly to the extent that it does in other cancers. But it's the effects on the insulin signaling pathways that actually mediates the effect. So you may not be an expert, but you certainly know a lot more than I thought you might.
This is Rich. I'm back. I'm sorry about that. I dropped off. But I have a question, and I gather you're talking about the ketogenic diet again, and the glucose and insulin. But the question I have is that if prostate cancer responds more to insulin, then would we expect to see a higher incidence of prostate cancer in diabetics?
That might be the case. I mean, it follows. I don't know that anyone's ever looked. though. So I don't know what the answer is.
But I do know that the metformin studies. I mean, the reason that they felt that metformin was effective, one of the reasons, was because they noticed that men who were taking metformin, who had prostate cancer, seemed to control it better than those who did not. And most of those men were diabetics. But I don't think it was a diabetic study. I think it was more a study related to the metformin.
Right. I think they were, yeah, exactly. These were guys that were taking metformin to control their diabetes, and the question was whether or not it would have an effect. So it wasn't it didn't directly address the question.
Right, and I think what they saw was that men who were taking metformin had a lower incidence of prostate cancer than men who weren't taking metformin. But then, of course, the question is, what were their what was their diabetic status of those two people? But explain to us a little more, Dale, about this. The point that Don raises, which is a really good one, about this difference between the glucose and the insulin, and why the insulin is sort of more pertinent.
First of all, let me backtrack a little bit and say that the diabetic patients that are taking metformin are mostly type 2 diabetics, and they're not necessarily taking insulin at the same time, or as part of their treatment. I mean, there are some type 2 diabetics. So there's type 1 diabetics who depend on exogenous insulin, absolutely, and then type 2 diabetics who generally develop the disease later in life and don't always become insulin dependent. So that makes it even more difficult to extrapolate from these studies with metformin to just the question of how insulin is working. So the glucose dependency of other chemicals. Okay, I'm waiting for the boarding announcement or whatever.
I'm sorry. Let me mute.
So the glucose dependency of tumors, and not dependency, but it's frequently referred to as glucose addiction, refers to a phenomena where the metabolism in the body of glucose switches from something called the TCA cycle to something called the glycolytic cycle, and which requires much more glucose to generate the same amount of energy. And so the tumors, for that reason, require large amounts of glucose. The insulin signaling pathways are also, insulin is a growth factor. So it binds to the surface of cells and, to a receptor, and then triggers growth signaling pathways that cause growth. And this is somewhat different from glucose, which can act as similarly to a growth factor, but by acting through very different pathways.
Mm-hmm.
So for prostate cancer patients, it becomes more important to block the insulin signaling pathways. Does that answer your question?
Yeah, I think it does. Don, did you want to comment?
No, that sounds right.
Okay. Well, it's an interesting discussion. Anybody else want to say anything on this whole issue of glucose and insulin and ketogenic diet? Paul Frieda, this was an area that interested you quite a bit.
This is Don.
Who initiated it.
Yeah.
I'm the one who initiated the discussion. Yeah.
That's right.
This is Don Price again. One other thing, just to throw this out also, is that, so anything you can do that will keep your insulin response down would be potentially a good thing. And so I would say that studies do show that exercise can keep the insulin response down.
Yes.
Yeah.
That is absolutely correct. Yeah.
Okay. So, Neville, Neville Black, have we convinced you that maybe you should start exercising?
I tell my oncologist I have to keep something in reserve for when Eligard fails.
Okay. That's a good.
I would argue with you, but you can't argue with success. Once your PSA starts going up again, though, then I'll start making the argument.
Oh yeah, no, I'll agree with you then.
No, Rick has been a strong proponent of exercise for all the time that I've been participating in this call, and I also am a firm believer in exercise for many reasons. Not just because of its impact on metabolism, but also because of its ability to mitigate some of the side effects of drugs like Eligard. I was clobbered when I first started taking Eligard, for example, and I was being treated for a different tumor at Sloan Kettering, and I spent a lot of time in their rehab medicine clinic, and they convinced me that the only thing that really would help me with, I had just massive joint pain in every single joint. I could barely move, and they told me that the only thing that would really help it first they told me that it was because of the Eligard and in my case combined with lengthy bed rest after the surgery that I had there, but they said that was exercise really was the only thing that would solve the problem, and then they prescribed a year of intensive physical therapy, and by the end of that year, I felt so much better. I mean, I'm a really active outdoorsman, and I up here in Vermont specifically for one of the big reasons, in addition to visiting with Rick, hopefully tomorrow, to climb mountains, of which there are none in Buffalo, where I spend the rest of my time. And it really does make a difference. But I suspect, Neville, that you get more exercise than you're letting on.
No, I've got a running machine and an exercise bike, but I just will not get on that exercise bike. It don't matter. I've been on it a couple of times, and I just don't like the seat on it at all. So I refuse to get back on that. But I've got a son that uses it, so that's not going to waste. But I've got a running machine, and but I haven't lowered it down to the floor for well over 12 months.
Okay.
Well, Neville, there's always the possibility of changing the saddle on that bike. You might want to think about that.
Look, I'm aware of all the different, a number of different studies that say exercise is beneficial, but I'm not naive to it. But yeah,
okay.
But as I said before, I've got to keep something up my sleeve for when Eligard first fails.
Okay. Well, I'm much looking forward to exercising with Bill the rest of this week if I ever make it out of JFK, and we'll give you a report next Tuesday night. Is it Tuesday? Yes, next Tuesday night, as to what exercise we've been doing together. Let's move along here, and let me first check, see if anybody else has come on the call. So here's the list of the people that I'm aware are on the call. Jake, Bill Franklin, Dennis Correa, Don Price, Eric Bookbinder, Neville Black, Jim Harrington, Paul Frieda, and Bill Burhans, Professor Bill. Anybody else on the call?
Jay Curran.
Jay. Hello. How are you?
Fine.
Okay. And is there anything you'd like to talk about tonight?
Yeah, they want to put me on Zytiva.
Okay. So we'll come back to you. I've got you down. Anyone else other than Jay who just joined us?
Rick, this is Len Sierra.
Hello, Len. How are you?
I guess I missed the first half hour. I'm curious to know how you wound up at JFK, but we can talk about that later.
Yeah, I'll call you afterwards. Bill Franklin, why don't you tell us what's on your mind?
Yeah, that's good that you said that when you did, because it kind of ties into what we were just talking about. So I was curious. I'm at the tail end of my Lupron treatment. I've had my last shot. It'll be 21 months worth of treatments, and then I'm just waiting for it to wear off now. And last month I had a bunch of blood tests, which was my primary care physician gives them to me annually. And I saw my cholesterol levels and my serum glucose all went up. They went up to, above normal. And I was wondering if anybody else experienced that. I have read that this can happen on, Lupron and ADT treatments. But for the whole first year and a half, almost 2 years, all my blood tests were great. And then all of a sudden, except for triglycerides, I've always had a problem with those. But everything else is great. And now triglycerides are even higher than they were before, and LDL went up, total cholesterol and serum glucose all went up into what they, would categorize as red range, So I was curious if anybody else had seen those kind of climbs for prolonged ADT.
Let me ask you, when you say your cholesterol went up, do you have, beyond the total cholesterol, do you have a breakdown of the cholesterol?
Oh, yeah, I got a lipid panel for, so my triglycerides have been over 300 for over a year.
Right.
They were at 314 this time, up from 302 a year ago.
And
good.
The reason I ask you about your the panel is because I'm wondering if your ratio stayed the same. In other words, the ratio of your total cholesterol to your bad cholesterol, did that stay the same, or did that go up?
Look here.
Total to, what's your HDL? What's your HDL and your LDL doing during this period? Are they staying in the same sort of ratio?
My HDL is 40, which came way down from the last test. It was 48.
Oh, wow, yeah.
Came down to 40 from 48, but my LDL climbed from, gosh, it was like 85 up to 138 in a year. So
wow.
And total cholesterol also did a climb.
So I'm...
Yeah, total cholesterol too, from 192 up to 240, 241. And my glucose went up, so I haven't done anything different. I've been on a very similar diet the entire time I've been on this treatment.
I guess what I should have said was I said I identified the ratio incorrectly. I mean the ratio should be the HDL to the total cholesterol, and normally for most people that's around 4. In your case, it sounds like it's quite a bit higher. I've always been lucky. Mine's always been pretty low. I have a very high level of good cholesterol, but I also have a high level of cholesterol overall. To answer your question, I mean, certainly for me and a lot of other guys, when you've been on Lupron for a period of time, or LHRH drugs for a period of time, it does appear that you start to see a rise in your glucose, a worsening in your cholesterol, in your lipid panel, possibly a rise in total cholesterol and a lowering of your good cholesterol and an increase in your bad cholesterol. Yeah, I mean, I think that's a fairly well identified situation or result of long-term hormone therapy. And anybody else want to speak to that? Bill?
No, I can't add any more than that, Rick. But I'm not sure anybody really knows why. But that's,
no. Well, so I don't think it's unusual. I think what you're going to find, though, particularly given that you're a younger man, I hope, is that you'll start to see your testosterone come back pretty quickly. Len, were you on the call when Len told us about his testosterone coming back last Tuesday? I don't think you were on last Tuesday night, but Len, talk to Bill a little. Talk to Bill a little bit about. I mean, what's your cholesterol and your glucose been doing, and share with Len about your testosterone.
Me share with Bill. Yeah. Well, I think I'm a little unusual in the quick recovery of testosterone. 3 months ago, I was less than 4 while I was on ADT, and then I went off. And now 3 months later, I'm like mid-400s. So I made a pretty quick recovery.
For testosterone, okay.
Testosterone, yeah. And I'm just wondering, was it Bill Franklin who was?
Yeah.
Yeah. Are you on a statin? Because if not, you should be.
No, I wasn't on anything. They were all good last blood test. It's been a year since I had them, so. Well, not quite a year. It was October of last year, and then I got them last month in June. So.
Yeah, well, sounds like you should be on one now.
Yeah, I think
down your LDL almost immediately, I think. Was that all you wanted from me, Rick, or was there something else you wanted me to address?
No, I was just wondering whether your whether your lipid panel, your glucose, and your cholesterol numbers, whether they had worsened significantly the longer you stayed on LHRH drugs.
Right. Yeah. Not really. I mean, my glucose did go up a bit, but I don't believe it ever went above around 94, 95, which might still be within the normal fasting range. I'm not sure about that.
It is, yeah.
Yeah. And cholesterol had never been an issue with me, and it didn't really go up very much while I was on ADT.
Okay.
Maybe it's the exercise that you prescribed for me, Rick.
And I mean, I think that Len's advice certainly to discuss a statin with your doc is a good one. You know, the statin of choice is guys, help me out. It's just gone from my Crestor. Thank you. The statin of choice is Crestor, which is what I want to switch to once I get my health insurance reestablished. But yeah, I definitely would talk about that, and I talk about metformin as well, Bill. You know, those are both pretty innocuous drugs, and they both seem to be helpful in controlling prostate cancer. And certainly in your case, there seems to be good reason for you to be taking taking a statin. And you know, a lot of GPs now consider that you should be on a statin full time, just as a healthy measure, as a healthy heart measure. So what about, well, we got a bunch of guys who have been on this call who have been on LHRH drugs for a long, long time. Jim Harrington, Paul Frieda, Dennis. I mean, have you seen a worsening in your in some of your numbers over the period of time?
Not me.
You haven't, huh? Paul, yeah. Jim?
Yeah, Jim, this is Jim. No, I really haven't noticed that. I got other problems, but the cholesterol and these numbers, no, I nothing substantial, nothing that is worrisome.
And Don Price did not see a change in a year and a half on
Yeah. Well, you know, it's the same old.
This is
Yes,
Jay.
go ahead.
I've been on cholesterol. I've had a cholesterol problem and triglyceride for years, so I've been on medicine for that for a long time before I had cancer. But I did notice my glucose went up to almost the diabetic range.
Okay.
And that's why I'm taking the metformin. So there was that change.
You were taking metformin for high triglycerides, or?
No. I have been on medication for triglycerides and cholesterol prior to me finding out I had metastatic cancer. But then being on the Lupron for 5 years, I noticed my glucose did go up to the almost diabetic range. So at that point, my doctor, agreed to put me on metformin. So you're asking Rick was asking if anybody else had any metabolic, symptoms. And with me, it stayed the same for triglycerides and cholesterol, but the glucose definitely did go up.
All right.
This is Bill Burhams. I've been on Leuprolide for 4.5 years and have had no rise in any of the lipids or in blood glucose.
But you're on metformin, aren't you, Bill?
No, no. I put myself on them, but I ran into some significant nausea problems, and then I had surgery in April, and things became too complicated. And I'm planning on going back on them.
Okay. Just make sure you take it with a meal.
Yeah, you gave me that advice last time. I'm keeping that in mind.
Yeah. And you might also want to ask the doctor for extended release version. That helps, right. I think, a little bit too.
Yeah, okay.
And Bill, what was giving you the nausea problems, do you think?
Well, this is just it's a known side effect of metformin.
Yeah.
And,
okay.
And, I'm not sure that anybody knows why it occurs, but Jake's advice, I think, was really good.
Okay.
And I haven't gotten around to trying it yet. I'm taking like 30 pills a day, and I just, that's a stupid reason not to be taking it, and I need to go back on it, but I just haven't done it yet.
Mm-hmm. Well, I mean, in my own case, I definitely had a worsening. I mean, my glucose crept up, and after it got up to around 11, the docs just said, it's probably the LHRH. When you come off of it, you'll be fine, and they were right. I mean, it still stays up there, right at the upper level of normal, but it's always been that way. So I just say, well, I figure that's just me. And I would also say that when I was treated, metformin was a much more radical concept. I mean, Snuffy was pushing it, no question, but he was it was very controversial. The doctors weren't as willing to put you on metformin as they are today. So I never really fought for it, and I mean I probably could have gotten it because of my sugar levels. But I do think today, and you've heard us say it enough times on this call, that in this group that everybody who's resting with recurrent and advanced prostate cancer should be asking their doctor for a statin and for metformin. It's definitely positive. So
I'm not.
Yes.
I'm not so keen on statins. They have side effects that are potentially damaging. I'm not so keen to start taking statins. But the metformin, I've looked at the studies. I also, my oncologist refused to prescribe it, and
right.
And so I had to go back to my primary care physician to
right.
Get the script for it. But
right.
I've looked at the studies, and it really does have a potent anti-cancer effect.
Right.
It's really
right.
crazy. It's crazy that I'm not taking it.
Right. Well, I mean, the one thing I would like to say about the statins is I think people respond to different statins in different ways. In other words, yes, some people get muscle cramps from statins. We know that. Other people, it doesn't affect them at all. I mean, much like with many of the different prostate cancer treatments, it's really different for each guy. But having said that, I think it's worth discussing. And if you find you're somebody like Bill who doesn't tolerate statins well, then you can switch to statin. I've been on simvastatin now for probably 10 years. Who knows? I may go over to Crestor and I may have a hell of a problem with Crestor. I might not tolerate it at all well. I just moved, by the way. I'm trying to get away from the announcements because I know that they're disturbing you, and I apologize for that. So hopefully, where I'm going to be sitting for the remainder of the call, there'll be less noise. So let's keep moving along. Don Price, you said that there was something on your mind that you'd like to talk about tonight.
Yeah, I'll be real quick. And this is maybe more for information, but and I don't, diagnosed in 2014, radical prostatectomy, high risk, 4+3, PSA about 20 going in, seminal vesicle invasion, and left a margin, and so had radiation, and have been using Schultz in Marina Del Rey, and this is a dietary thing, so I just throwing this out. So it turns out that that ever since for the last roughly 2 years since radiation, roughly, my lymphocytes, which are one of the white blood cells, have been out of spec low. So mine's been like on the order of, and I don't remember the units, but the normal range is like, I don't know, 1 to 4 or something like that. And mine's been about 0.4, decimal 4. So, and it's just stayed like that for a year and a half, and so I eventually went here to an immunologist who said, and Schultz had me taking, some amount of supplements. And so the immunologist said, let's see what happens if you stop taking turmeric. And I did for a month, and it doubled. The white blood cell count doubled. So, I'm just throwing that out there for information. Some studies would say that with a low, the immunologist would say with a white blood cell count, with a lymphocyte count that low, you're at risk if you ever get pneumonia or, other kinds of serious infections. Some people would say that, and of course, turmeric is an anti-inflammatory, and there's probably a correlation between at least white blood cell count and how much inflammation you may be experiencing for various reasons. So some people would say that there's nothing wrong with having a low lymphocyte count. The issue is, if you get an infection, does it ramp up quickly? So, and I don't know, and he didn't know the answer necessarily, but he thought the immunologist thought it was a bad thing. So I'm just throwing that out for anybody else that might come upon the same issue for them.
Really interesting. Interesting because, by and large, you know, we talk about the positive impacts of turmeric, and nobody ever says that it could cause harm, and it's the first time I've ever heard it mentioned that it can impact your white blood cells. I'm wondering if this is something that is known, if there are proven correlations between turmeric and the white blood cell and the white blood cell count. I mean, is it something to do with the physiology of it being an anti-inflammatory? I don't know enough about the biology to know whether an anti-inflammatory is going to reduce your white blood cell count. Does anybody have any idea on that?
So this is Don Price again. My understanding is that yes, that in essence, white blood cells, the more inflammation you have in your body, for whatever reason, you know, because you got hurt or because you're sore from running, you know, the more inflammation, that white blood cell count, of which lymphocytes are a subset, you know, goes up. It is correlated to a marker of inflammation.
Oh, I see. Yeah, that would make sense. In other words, the more inflammation you have in your body, the more white blood cells there are, the more white blood cells are needed to fight the inflammation. So if you have little inflammation, you have fewer white blood cells. I mean, it would make sense, but I thought you want white blood cells because they're the good guys that help you stay healthy. And how do you get white blood cells, lots of white blood cells, without inflammation? Bill, Professor Bill, help us. Is this within your realm of knowledge?
No, it is not. But it's very interesting. I have chronically low white blood cell counts because Lynparza knocks them down. The PARP inhibitor that I'm taking, and so
right.
I'm not taking turmeric, so it's not going to change anything. But it's interesting. I'm going to look into this.
Okay, we got plenty to talk about when we go for a hike in the next couple of days, Bill.
Yes. Yeah.
That's a really good one. Tom, thank you. I mean that's it's really intriguing. What was your immunologist take on the turmeric? I mean, what made him even suggest?
Yeah. I think it was just he knew that it was an anti-inflammatory. I don't know. I don't know. I don't know the answer to that. I didn't ask him why. He even said, I doubt it makes much difference, but just out of curiosity, let's try it. I'm going to see, just so happens, I'm going to be in Marina del Rey to see Schultz in a couple of weeks, and he, the immunologist, said, ask your oncologist what he thinks about it. So maybe I'll have some more information in a couple of weeks.
Yeah, that was my next question. What's Mark Schultz got to say about this? Well, will you please let us know? It'll be really interesting to hear. It's a shame you don't have a Don Price. It's a shame you don't have a appointment with your oncologist in Marina del Rey right around September 8th.
Yeah, I know, but I don't.
But you don't. Okay. Well, give me a heads up when you're going to be in. What dates are you going to be in LA? Because I'm going to be in LA in a couple of weeks as well. I might be before you.
I'm going to be there the 20th through the 27th.
The 20th through the 27th of July?
Correct.
Oh no, I won't be there until August. I'll be there in mid-August. So that's a pity. I would love to have seen you there. That was great. Somebody just wanted to get in. Who was that?
Yeah, that's me, Rick. It's Len.
Go ahead, Len.
So there have been there has been some literature on what they call the NLR, neutrophil to lymphocyte ratio. The neutrophils are the white cells that fight bacterial infections. Lymphocytes are more likely to be fighting viruses, cancer cells, and direct killing activity of foreign bodies, but other than bacteria. If your NLR is higher than 4-to-1, so if your neutrophils are more than 4 times higher than your lymphocytes, this is supposed to be, the studies they've done show that this is a negative prognostic indicator for prostate cancer. And that's unfortunate for me as well, because my NLR ratio is 5-to-1. So my neutrophils are much higher than my lymphocytes, and I think that came about after my radiation. And according to Dr. William O. at Mount Sinai, the high neutrophil to lymphocyte ratio is a sign of chronic inflammation. So I think that inflammation is, the high neutrophil count is more a marker of inflammation than is a lymphocyte count.
So a high...
Whatever that's worth.
No, it's worth a lot then, and maybe we can just unpack that for a minute. A high NLR ratio is significant of inflammation. Is that what you're saying?
Yes, and also a negative prognostic indicator for prostate cancer. So people with, let's say, high-risk prostate cancer with an NLR greater than 4 don't do as well as those with an NLR less than 4.
Really, this is great, man. I'm certainly learning a heck of a lot on this call, and I hope everybody else is.
I asked Dr. O, is there anything I could do to get the lymphocyte count up? And the only thing he could suggest is, he said, well, you might want to try taking a low dose or baby aspirin, coated baby aspirin, as an anti-inflammatory, once a day, which I believe is still recommended for patients for good heart health. I think so.
It's recommended. It's been recommended for years, both for prostate cancer and for other cancers. I've been taking it. I take a daily baby aspirin and have done for as long as I can remember now. Probably 5 or 6 years. My memory's not so good as I get older. So for that 5 or 6 years is about as long as I can remember. But I have been taking. I've been taking low dose baby aspirin. There are some good studies on that. I think there's a couple of referenced on Mike Scott's site, New Prostate Cancer Info Link. If you go there and throw in aspirin, you'll find some reports that he's done on taking aspirin for cancer, and especially for prostate cancer. But that's also interesting that the aspirin brings up the lymphocytes, and so it lowers the ratio. Is that what? Yes.
Specifically say that the aspirin will increase your lymphocyte count. He just said that a high NLR is generally assumed to be a sign of chronic inflammation, and so he suggested taking the baby aspirin to reduce the
I see.
level of inflammation. Now, maybe that means the
ratio
changes even if the lymphocyte count doesn't come up. Maybe the the neutrophil count goes down. I'm not sure.
I see. Anybody else want to get in on this discussion? Okay. Well, again, this is all good stuff that we're talking about here. Okay, so I'm looking for my list here. I'm going to keep moving down my list. Eric, bookbinder.
Rick,
Well, go ahead.
I was going to say we have a new caller. If you want to touch base with him.
Oh, please go ahead. So, somebody else has joined the call. Who is that?
Richard Foodie?
Oh my gosh. Another voice from the past.
Here I am.
Mr. Foodie, welcome back. Okay.
Thank you.
Did you need some time tonight?
No, I think in a nutshell, all is good. I'm about the same. I can just do like a quick summary if you want, or just or.
Okay. Well, let's see how. Okay. Let's see how. Let's keep going down the list, and we'll come back to you if we've got some time.
Okay.
But it's very good to hear your voice on the call. Eric, take it away.
Okay, well, I saw Dr. Agarwal today. He's the medical oncologist in charge of trials at UCSF.
Right.
So I'm going to be starting Xofigo a week from today.
Okay.
And, I started Zytiga, I don't know, 10 days ago or something. I just got the result of my PSA back. It's almost 20 now. And we discussed, I showed him the list that came up from the California Cancer Institute, and I don't know, he was kind of dismissive of it, but he looked at all of it, and he said, there are some studies that they have that are more appropriate than the ones that showed up on this list. So
let's just recap. Let's just recap for the people who might not have heard that Eric attended a Cancer Research Institute immunotherapy summit presentation about a week and a half ago, and then subsequently Emerging Med and Foundation Medicine sent him a list of potential trials, correct?
That is correct. After, comparing my studies to what the requirements are, so, they had a full medical history on me, well, not full, but it's showing that they had a treatment history, and based on that, they came up with 7 trials. The closest ones were in L.A. Interestingly enough, it shows how many miles away from where you live the studies are. I guess, as far as my treatments go, that I'm starting Xofigo next week, and that my PSA is continuing to rise rather dramatically. I know that it's not up in the hundreds or thousands like some of the other people, but considering that it was 5.5 when I had my prostatectomy, and now it's 20, the progression is not good. So I'm hoping I haven't been on the Zytiga long enough, and I haven't started the Xofigo yet, so I don't know what results I'll get from those. I'm hoping that we'll see something. Go ahead, Rick.
Okay. I was going to ask you a couple of things. The first thing is, how are you managing on the Xofigo and the prednisone? Any adverse effects that you can tell, or do you feel just like you did before? Anything good, anything bad?
No side effects at all from them. I was in a lot of pain. I told you that, and then they got me on the morphine sulfate ER twice a day, and I was still getting pain. So now I'm on it 3 times a day, and that's pretty much solved the problem.
That's great.
Okay.
I'm glad to hear that.
Yeah, that's really good news that this extended release is helping you out. And what is with this PSA increasing, what is your alkaline phosphatase doing? Is it going up as well? Is it staying steady?
Yes. No, it's going up.
It is going significantly or not?
I can tell you exactly in just a second. Let me.
So for those of you who want to know why I'm asking that question, I think some of you do know, but for those who don't, the PSA is only one marker. It's a marker we rely on a lot, but it isn't necessarily a terrific marker the more advanced the cancer gets. And what most people, most docs will tell you is that they like to rely on comparing scans, but you can't get scanned every 2 weeks. So we have to have something in between those scans, and there are other markers, as we've been talking about tonight. I mean, for example, this ratio is something that I've learned about tonight, and something we can always be looking at when we do complete blood counts, and the numbers come back, and I always wonder to myself, well, what's the relevance of lymphocytes and neutrophils? Well, now we've learned one thing that we can be extracting out of that information. But another thing is alkaline phosphatase, which is a measure of bone activity. So it's going to tell you how much activity is going on in bone formation. The problem, of course, with alkaline phosphatase sometimes is that it can be high if bone is being destroyed, and it can be high if bone is being built. But what we tend to think is that when that alk phos is going up, then there's more activity going on in the bones, and probably it is not as positive as we would want it to be. Anybody else? I mean, that's my non-medical assessment of alk phos. Anybody else want to contribute anything else to that?
No, you're exactly right, Rick, and that's what Dr. Steve always talks about. Dr. Steve's always talking about the alkaline phosphatase.
That's right. That's right. But was that you, Eric, that wanted to come back in there?
I'm sorry? I was just going to say that they haven't been testing it every time. So I have one year ago that was 66, and now it's 122.
Okay. But even at 126, Eric, that's not bad. I mean, talking about Dr. Steve, I mean, he was looking at levels up in 180 to 200 plus, and now it came back down from there. So anybody else? Does anybody else have any alk phos levels that they can of their own that they can relate to the 120 that Eric just mentioned?
This is Jay Curran. I have 63, and my provider said that it's a lagging indicator, but you probably already know that. I mean, PSA may come down sooner than, okay.
No, that's good. It's more good. I didn't mean to shut you up, Jay. I mean, keep talking. What else did Chuck say to you about that?
Well, it was a nurse provider, but they just said that it's another marker that they use, and that just another backup that kind of confirms what they originally thought about something. That's as close as I can get to it.
Okay. Anybody else have anything to say about alk phos?
I can tell you my alkaline phosphatase has varied between 90 and 100 over the last year and a half. And according to the panel that I have here, it says that when you get above 115, then that's a problem. and
Right.
I'm sort of at the high range, but I've stayed under the the troublesome number. So.
Right. And that's really important for you, Eric, because you're barely over the normal range. And in my own experience with so many drug tests, so many blood tests, is that normal range is pretty flexible, and the doctors will often say to you, well, you don't have to worry until you're 3 times the normal range with some of these. I mean, I'm not saying that about alk-phos, but I've certainly had stuff that's been over the normal range, and they say, oh, you don't have to worry about that. The normal might be for whatever it is, 120. They say, oh, don't worry until it gets to over 400. I mean, it's not 126. Is not a super high number. I mean, I just want to give you comfort on that. That's all.
And Eric, Eric, this is Jake. You might find that once you're on the Zytiga for a little while, your alkaline phosphatase might go back down. I know mine went down about 10 points since I started Xtandi, so hopefully you'll have a similar response.
I'm looking at my past results from the other medical oncologist, and I was hanging around 70 all through last year, and then there's a large break where they didn't take it. But in June it was 96, and at the beginning of July it's 118, and a week later it was 127.
Yeah, but you've only been on the Zytiga for, 10 days, you said?
Right.
Yeah. So I don't know if it'll have an effect, but hopefully it will. I know it did have some effect on mine with the Xtandi, and maybe you'll have a similar effect with the Zytiga.
And how high was yours, and what did it come down to, Jay?
The highest mine was, I think, was like 73, and it's now down to 54.
I mean, I'll say one thing, Eric, which is that it really supports the Zytiga. I mean, this is probably the best time for you to be doing the Zytiga, and if the Zytiga is going to have any impact, it's a good time to be taking it. So,
yeah.
And where are you going to do that? At UCSF, or are you going to do it at Sutter?
Sutter doesn't do it. It's at UCSF.
Okay. All right, and the first shot next week. So, Steve's done it, so you can, if you want more information, you can always give him a call. Let me know. I'll be happy to. I'd be happy to send you his number if you don't have it. But yeah. So let's
Thanks.
Thank you. Thanks, Eric. Let's keep moving along. Jim Harrington.
Yeah, hi, Rick. It's Jim. Yeah, I can talk a little bit about this trial. First of all, my alkaline phosphatase is 200, and it's related to tumor burden and so forth. But this trial the trial I'm speaking of is pembrolizumab or Keytruda, which you can see advertised on TV a lot. It's made by Merck, and combined with Listeria. And I don't know, I guess I've had 8 infusions. Every 3 weeks I have an infusion. So to kind of get to this quickly, it's not the most pleasant stuff, even the pembrolizumab, which, by the way, has been very successful in various cancers, including a recent report. I haven't read the whole thing, but Snuffy Myers newsletter reports some excellent results with pembrolizumab. But I've not had any genetic testing, but there is certainly combinations that seem to be helped very much by it. But basically what I can tell you is that it's not clear. I mean, I go in and I have these infusions, and I don't feel so hot the next day. As my oncologist said, I'd feel crappy the day after the infusion. It's generally true. And then you wait 72 hours, and you take your ampicillin, in my case, to kill the Listeria, which they just put into your body 3 days ago. And, it's not much different. The only thing that happens, and it happens to almost everybody on the trial, is that during the course of the Listeria infusion, which is about 2 hours, you can get chills, and these chills turn into Rikers or to the shakes. And so in my case, they call a code yellow in the cancer center, which all that means is that 6 people rush in and look at me, shake, and they give you Demerol. And the Demerol is a very old narcotic, and it's about its only use is to stop these shakes. And it works. In about a minute or so, you stop shaking. But you can't stop it. I've tried. All you do is you look at these 6 people staring at you. Anyway, apart from all that, the trial goes on. I'm going to have some more bone scans and CTs. I don't pay for any of this. This is all paid by the sponsor, Advantex, who makes Listeria. It's not really too bad. I mean, you don't get really very, very sick. You just have to watch taking ampicillin, in my opinion, because it can affect your stomach a little. So I take keeps me from getting nausea, and I take that pill each day. But other than that, right now, my PSA is going up a bit. You know, Rick, many times we talk about the fact I don't make a lot of PSA. I guess it's true. But anyway, it was a 3-week period from the last infusion to this current one. It went from 3 to 5. Now, I don't think that's particularly good. My med-onc doesn't think there's any worry. You got to see the scans. It's the scans. But there's one thing I got to tell you that's happened to me, and it's really not apparently related to this trial, is I'm anemic. And that is no fun. And it looks like I'm anemic for life. And so I've had transfusions. I've had a lot of transfusions of blood. And they give it to me maybe every 3 weeks prior to giving me, because my red blood count cells are not high enough to go and get the infusions in the trial. And to give you a number, most men would have red blood counts of 12 or above. Mine has been 9 or 8.5. And if it's 9, they can go ahead with the trial, or it's 8.5. But once it went to 7.4, and I'm here to tell you that's pretty anemic. And what they can do about anemia is give you blood. Now, in the past calls, I think Dr. Stevens ever suggested there's ways to look at my blood, my other platelets and this and that. Well, they did all that, and they say there's nothing they can do but give me blood. It's not hard to get a transfusion. I mean, they check the blood very carefully. But anyway, I thought it's connected to Pembro. And you can see where it might be, but the doctors say this is not the case for me. It's the cancer. What happens is the cancer infuses into you.
Let me ask you a couple of questions.
Yeah, sure. Fire away.
So, what's your hemoglobin? Is that the number you're giving me?
Yeah, the hemoglobin. It's about 8.5 to 9. And when they give you the blood, it goes up. You know, and
Right.
So when it gets up to 8.5 or above, they can go ahead with the trial. But if it's lower than that, they cannot.
So when it's down to around 8.5 to 9, are they giving you a couple of pints?
Yeah. Yes.
Right.
Two units of blood.
Right.
Yes.
2 units.
And you know, the idea, Rick, is that you just blossom like a flower, like you water a plant, and boom. And see, in the trouble with anemia, you get shortness of breath, and you get fatigue, and you do. I mean, there's no question about it.
Right.
And I don't blossom like a flower exactly, but you feel better. Just keep putting blood in me, and then you feel better.
Right. And what about your platelets? Are they?
I don't know. I don't have those results in front of me. I don't know, but there's problems with the platelets, the white count, and so forth. I believe the last time. So I mean, I've got this to deal with. But on the trial itself, I don't know how long they'll keep me on it. I don't know what's going to happen to me. I'm a little discouraged because my PSA is going up, but they don't seem very discouraged. It's not that high. It's just hard to say. I mean, I think that there's no question that pembrolizumab can be helpful to people. I mean, you can just you have to read about this.
Your PSA, as I recall, went down to begin with. Didn't it go down from 3 to 2.5 or something?
Yeah,
I don't have the numbers in front of me today.
No, that's right, Rick. It did. It went down, and I was really happy. And it then went back up a little bit. Now it went from 3 to 5. That's correct. So it's not. I mean, I just keep doing it until they. The next step will be. I got bone mets in my spine, all over my spine, into my hips, and so then if I can't stay on the trial and if it's not working. I'm sure I'd go on Xofigo, try to get rid of some of these bone mets and get my alpha alkaline phosphatase down.
So, here's the concern about that, and here's where you have to be really, really careful, is that it's not good to go on Xofigo if your blood counts are already compromised.
And I think they are a bit, well.
And so, in a sense, what you've got to, because it does sound like you're a good candidate for Xofigo.
It would sound that way, and
interestingly enough, yesterday I reviewed a paper that's been put out by UCSF for another one of their pamphlets on advanced cancer. And it's supposedly authored by Chuck Ryan, although I think it's usually a committee of people that write it and they sign off on it. And there were a number of, Bill also happened to look at it too, there were a number of omission errors that were quite disturbing, and I wrote them up and I sent them over to somebody so that UCSF sees it. And one of the things, I think probably the single thing that bothered me the most was a reference to Xofigo without advice that you should not be considering Xofigo if your blood counts are compromised. In fact, this report said that you can do Xofigo and chemotherapy at the same time. And that's absolutely wrong because UCSF actually did a trial, and Jerry, God rest his soul, was on that trial, and that's what finished him off. And then the trial was to see some men did Xofigo, some men did Xofigo plus docetaxel. Jerry did Xofigo plus docetaxel, and it was too heavy. And so, what I'm saying is that Xofigo sounds great, but what we've got to do first before you go on the Xofigo is get your blood counts up to a level where you can tolerate the Xofigo. And
I think you're right, Rick.
Be at the front of your mind.
Right, and right now, of course, I'm still in the trial, and when you're on the trial, you can't take Xofigo. You can't do that. You can't take any chemo. But I'll keep that in mind when we get to that point. I'm hopeful that I can stay on the trial. I can handle it. It's not chemo. It's not as bad as docetaxel or something from listening to the guys in the call. You really don't. The worst thing is to be anemic, a little bit anemic, because that means you walk up a few flights of stairs, you're puffing away,
And you're puffing away. Yeah, I know. I mean,
it's not fun.
I've seen it with enough other people. At the same time, I don't think you've done chemo, and I was
I haven't.
And I was with Ken Anderson last night, and he's tolerating the chemo exceptionally well. Yes, he's got some issues from it, but we don't know. Some people tolerate this stuff well, and then there are people like Eric, God bless him, who had a horrible time with chemo. So we just don't know. I mean, you may tolerate chemo well, whereas you're not tolerating other things, and maybe chemo's the thing that you've got to do to get at this.
I think you could be right. I think you could be right, Rick. The doctors are right now so concentrating on the trial, and the bone mets that they're not worried about that because they think of one thing at a time. And but the anemia can be controlled. I mean, everybody knows that if you give enough blood, you'll be fine. And how often you have to give it depends. But basically, they claim that the cancer has gone into the bone marrow, and cancer cells are replacing the red
that's
cells.
Right. I mean, that's exactly what's happening. And we know that it's called myelosuppression is the medical term for it, and you're suffering from myelosuppression. And what can we do to stop that? Well, we got to get at those cancer cells. Right. If the pembrolizumab isn't going to do that, then we've got to think about other things. And the one thing I would encourage you to consider is that you're not a mouse, you're not a trial animal, and if you think it's gone far enough, then you've got to say it's enough. I've got to try something else, because if you let it go too far. If you let it go too far, Jim, you're not going to be strong enough to tolerate some of the other treatments.
Yeah, no, I think you got a good point. I am very concerned, And I think they are concerned too. But that's right. I mean, being on a trial means you are a mouse. You are an experiment. And yes, you can be helping people in the future, but I'm still the experiment right here. And I agree with you. Right. And I appreciate your advice. And you always give good advice. It's just too bad you moved from San Francisco, because I got to be out there in a while. I'm going to go to Hunan home by myself.
Okay. Now, the one thing is that, I don't know that you have that good GU med-onc on your team outside of, the
Stein?
What Schwartz, or what's his name?
Stein, Dr. Stein.
Right.
He's the
med-onc. And he's very committed to this trial. So,
that's true.
I would be lining up an appointment with another GU med-onc to get another opinion.
Yeah. Well, I got the name at MSK, and I got the phone number. I think you gave it to me anyway. I have that, so I just haven't done it. So it's my fault to get a second opinion about this.
Well, yes, and again, I've had a couple of bad reports on not bad reports, but less than positive reports on Michael Morris recently. I've got somebody else who's not happy with Susan Slavin at all, but now intimidated that they can't move away. I mean, I'd come back to Richard Booty's champion. I'd come back to Dana Radcliffe, because
that's the name you gave me.
Well,
hi, Richard. By the way,
she's very compassionate.
Hi.
She is caring, compassionate. She's smart. She's on top of all these new trials. She's publishing stuff, and from being somebody who was at the back of the pack for me when people talked about Memorial Sloan Kettering, nobody ever talks badly about her. Yeah. And most people, like Rich, did talk very well about her. And she's probably easier to get an appointment with than Howard Scher or
yeah,
Michael
well, I think
Morris
Scher would be impossible almost. But I do have her name and I do have her number. So thanks, Rick.
And you know what? If you decide that's what you want to do, tell me and tell Richard, and both of us will write to Dana Radcliffe and tell her to look out for you.
Oh, okay.
And it helps. And she'll probably
that's
back and say
good.
So just let us know when you're ready, but don't leave it too long, Jim, please.
Okay.
Yeah.
It's too bad that
I'd be pleased to help make an introduction for you.
Yeah, well, thank you, Richard. I remember we met. It's too bad Rick is at JFK, because we could be meeting at Grand Central Terminal tonight and eating the three of us. That's okay. Anyway, thanks, guys. Appreciate it.
It's a pleasure. Okay, let's keep moving. And I've heard a couple of beeps. I'm not sure if people are joining or leaving, because I can't see you on my screen today. Do we have anybody that's joined recently?
No new people. But before you go on, Rick, for those of you who are on the web, if you look in the chat box, our intrepid researcher, Len Sierra, has posted a link to a study about the neutrophil and lymphocyte ratio. So.
Okay, and great. And Len, would you be kind enough to email that link to me so I can read it tomorrow?
Sure,
Thanks.
no problem.
Okay, let me keep going down my list here. Paul Frieda.
Yeah, I already had my turn. I'm fine.
You're fine.
I brought up the ketogenic diet. I brought up the ketogenic diet. We talked about it.
Oh, okay. Okay, so this was more on the ketogenic diet from you. Okay, you're going to be the expert. I hope you're prepping on all of this, Paul Frieda, because next time the ketogenic diet comes up, and if Professor Bill isn't on the call, you're the man we're going to turn to. I'm just giving you a heads up. Okay?
Thanks very much, but I'm far from the expert. I'm inquiring about it, and some of the videos that I've seen on the internet seem persuasive, but I realize that there's no telling who's talking there. So I just wanted to get other people's opinions and what people have heard about it. But it seems to me that if glucose is a key, that is, it feeds the cancer, and if you cut it down, and let your body live off of fat. It's hard to me imagine how everybody has missed that for 15 years.
Well, it's hard for Professor Bill to figure it out too, because he's been studying this for a long time. Maybe we should be nominating Bill for a Nobel Prize.
No, no, don't do that.
No. You already got your own parking spot at Roswell Park. Are they not as much in demand as they are at Berkeley?
I'm sorry. What was the question? Is it now?
I said you already have your parking spot at Roswell Park. They must not be in as much demand as they are at Cal. You know, at Cal, if you get a Nobel Prize, they give you a parking spot.
Oh, yeah. I would hope they would give me a parking spot. Yeah.
Okay. All right. Okay. So, moving on down. Jay Curran, you want to talk a little bit about your situation? Anything new?
Yeah. I did have surgery for inguinal hernia. They repaired 4 of them on my, below my stomach, in my stomach. Anyway, my PSA before that was 0.663. Now it's 1.107. And because of that conference in Chicago, they want to put me on Zytiga with prednisone. I think it's 5 milligrams. And I just don't like those side effects of prednisone.
Well, why didn't you ask them to consider enzalutamide instead? I mean, this is not medical advice. This is purely from the gut. But my belief is that enzalutamide is we're going to hear exactly the same results from early enzalutamide from the Prospect trial. One of the reasons I say that, and guys, you've heard me say it on this call before, is that within 2 days of Janssen announcing those results at ASCO, Medivation cut their trial from 1,560-something men, which is what was stipulated in the Prospect trial, to 1,483, and said that they were cutting off the trial right now, and they were going to be publishing results. And what I think, I'm sure the reason they did that, they cut the trial short, was because they probably have as good a result as the abiraterone, and they want to get it out there, because right now they're losing ground. I mean, this is a perfect example where a man is looking at an early second-line anti-androgen, and the one that's being suggested because of ASCO is enzalutamide, is abiraterone, Zytiga, and one of the big advantages that we know about enzalutamide is that it doesn't require the prednisone, or at least as somebody, I think Jake or somebody has pointed out in the past, it was actually at one point prescribed with prednisone, but it didn't seem like it was as necessary. So for whatever reason, they give prednisone with abiraterone usually, and they don't give prednisone with enzalutamide. So it raises a couple of points. One is, do you really need the prednisone with the abiraterone? There's probably nobody better on this planet to answer that question than Chuck Ryan, who happens to be your doctor, and who decisions like this, as I've said to you before, have to be made with Chuck Ryan. They should not be made with the nurse practitioners, with Nurse Rodfeld, or anybody else. These are too important a decision to be making with people that sometimes don't have a full deck of cards at their disposal, number one. Number two, you should be I would, if it were me, this isn't medical advice, this is navigation, I'd be talking to them about enzalutamide. I don't want to go on prednisone. I'm not happy about the prednisone. What about my going on early enzalutamide? And you need to advocate for yourself. So those are just 2 or 3 suggestions for you with respect to the Zytiga or the Xtandi. Is it a good idea to go on one of them? Probably is a good idea to go on one of them. The question is which is the right one for you.
Can I say something? Sorry. Neville Black, could I say something on that? Please?
Absolutely, Neville.
In Australia, there's prednisone is not terribly loved, but there's another steroid that they can actually use in Australia with abiraterone, Zytiga, and I don't know what the name of it is. I know it starts with D, but I know Jim Marshall will be able to tell you in a flash if he was on just exactly what that is.
Is it dexamethasone?
Yes, I think it might be. Yeah. Okay. It definitely starts with a D anyway. But
dexamethasone is often used for those guys who have been on chemotherapy. They've gotten prednisone, and they're on prednisone most of the time. They're on the chemo, and then they're also getting dexamethasone right around the period of the chemotherapy, the 3 or 4 days. The dexamethasone may actually be stronger than the prednisone.
It's just that some of the guys in Australia have been complaining about really, really high blood pressure on abiraterone. I don't know whether that's been found in America at all or in the US. And the other thing is abiraterone is when you abiraterone Zytiga, are you having dutasteride Avodart with it as well or not?
What's that word?
Dutasteride with the Zytiga, because it seems to work better with men that have Avodart or something like that with it.
Really? Well, and again, I don't know. I mean, I guess Don Price, if you're still on the call with us, has Dr. Schultz ever talked about prescribing dutasteride or finasteride along with enzalutamide?
Not enzalutamide, abiraterone.
With abiraterone? I don't know. Don may not be on at this point. I can't see. I don't think we've got anybody else. But prescribing something like a 5-alpha reductase to control your dihydrotestosterone along with other drugs is the sort of thing that somebody like Snuffy Myers or Mark Schultz is going to do on this side of the Pacific. I haven't heard. Now, Dr. Steve added finasteride recently because he was concerned about the level of his dihydrotestosterone even when his testosterone was so low. And I don't really know whether that's had an impact or not. And yes, he's on enzalutamide. He's not on abiraterone.
Yeah, no, the Avodart dutasteroids with abiraterone, Zytiga, yeah, not Xtandi, yeah. Enzalutamide.
But to go back to Jay, I would just encourage you to discuss one of the drugs, but advocate for the one that you want.
Okay. And they want to put me on Casodex. Does that make sense? Zytiga, prednisone, Casodex, and Lupron. I'm already on Lupron.
Okay. Yeah, I mean, adding Casodex, definitely, I can see why they would want to do that. But I think that you've got to decide whether you want the abiraterone or not. Let me just, I just want to touch base. Len, was there anything else you wanted to talk about?
Let's see. I know I mentioned something to you last time we spoke, and you said, yeah, maybe we should put that on the call, but I'm afraid I've forgotten what it was, Rick.
You and me both, boy.
Yeah, it wasn't terribly important.
Do me a favor. If you remember what it is or it comes back to you, send it to me in an email, and I will make sure that I have a note of it ahead of time, and then I will, because I do remember something that we did talk about, but I don't remember what it was.
You know what? I just remembered, Rick.
What is it?
mentioned in this forum some time ago and asked if anyone else had the same phantom smell, we'll call it, of chemical, right? Chemical or electrical burning.
Yes.
And so I asked that of my medical oncologist when I saw him last week. And, he looked very intrigued, but also a little bit cautious, like he didn't know if he should talk to me about it and worry me, because he said, well, it has nothing to do with, yes, I've heard that before, but it has nothing to do with prostate cancer. He said, the olfactory nerve is connected to the brain, and sometimes when people have that phantom smell sensation, they should see a neurologist. It might be associated with stroke, or in the case of a nephew of mine, he had that same sensation, and he had a grand mal seizure. I think that was all we talked about. Yeah.
Right. Well, that's encouraging for everybody, isn't it? Well, I mean, and we do know, by the way, that enzalutamide has a very minor association with brain aneurysm.
Right.
But it's really minor, and at this point, nobody even mentions it anymore. To begin with, it was sort of a big issue, but it was almost incidental. It could have been. It was so minor that it was barely greater than what was in the normal population, as I recall.
Right.
So,
Rick,
yeah.
Can I make a correction on my treatment?
Yes, sir.
I went on Firmagon today, so I'm not on Lupron anymore.
Okay.
So,
okay.
I don't know if that would make any difference. I don't think it would make any difference on your opinion between Xanthi and Zytiga.
No, none at all.
Okay.
I think the only person we just want to touch base with really quickly, and it's really, if anything is new for you, is Richard Foodie. Is there anybody else that's joined the call that I've missed? So if not, Richard, just close us out quickly.
Okay, well, it's good to be on the call, and you do a great job, Rick, and Jake and Len and all the others, and it's very reassuring to be in this community. I've been very lucky. Things are about the same. I see Dr. Rathkoff at Memorial Sloan Kettering every 3 months, and my PSA has been creeping up a little bit. Right now it's at 0.34. I've been on Lupron, Zometa for I forget how many years. A long time. And I've been on Xtandi or enzalutamide for 2.5 years. And so Dr. Rathkoff's not concerned about this creeping up at this point. However, there seems to be other things going on in my body that, I have a pulmonary oncologist that I see regarding things that are in my lung. I was a heavy smoker, or I was not a heavy smoker, I was, a standard smoker, and I stopped 3 years ago, but there's still some activity going on in my lungs, and they're not sure what it is. They don't want to do a biopsy because it's in spots where they don't want to risk puncturing the lung, so they're monitoring that every 3 months as well. But overall, and Dr. Rathkoff is collaborating with the pulmonary oncologist at MSK. I feel really good. I've been exercising regularly and eating as best as I can, and I try not to worry about things, and just try to live each day the best that I can. And I have my follow-up with Dr. Rathkoff in the first week of August, and we'll see what happens. My bone mets have been unchanged for 2 years. I do my annual bone met scans in November or December, and it's metastasized in my my sternum and in my right hip. So You know, when I first met Dr. Ratkoff, she told me I was incurable. She said, you know, but we can manage your disease. And you know, by the grace of God, I think she's done an excellent job of managing the disease.
Right.
And she's,
Exactly.
you know, she's got a plan, and you know, she knows what. You know, when I ask her, well, geez, what happens if? Don't worry about it. I've got that managed. I know what I'm going to do next if this happens. And you know, she said, you just enjoy your life, and you know, I know where we're going to go next if we have to, and but it'll, you know, depend on what the cancer does in your body. So
right. And I would also add that Richard has done a great job in terms of his diet and his exercise, and he's done an amazing job. So, you know, with this disease, we have to be proactive. There are things that we can control, and sometimes we don't want to, but the diet and exercise and stress, and if we want to make the treatments last for the longest possible time, we've got to do our part, which means that we have to manage diet, we have to manage exercise, and we have to manage stress. We don't have to, but if we want that to happen, if we want to manage for the longest period of time, then we know what is obligated of us if we want to fulfill it. So that takes us to the end. One thing before everybody hangs up that I want to just mention is that we've got a caretakers call. We've got a caregivers call tomorrow at 4 o'clock. I think it's 4 o'clock. No, 5 o'clock. It's at 5 o'clock Eastern time tomorrow. We got a I need to remember because I'm actually taking it because Renata is somewhere on the high seas. If any of you have caregivers that would like to join the call, it's always an interesting and a good call. Not quite as busy as this one, but just mention it to your significant others or your partners or whoever's taking care of you, and some of you come on yourselves because you give care, and we welcome you on the call. So,
Rick,
that's about it. Yes.
You said 5 o'clock Eastern. It's either 7 or 8 o'clock Eastern.
Oh, I'm sorry. I meant to say 8 o'clock Eastern. Beg your pardon. Thank you, Jake. Thanks for correcting me. I meant to say 8 o'clock Eastern tomorrow.
Okay.
5 o'clock Pacific. I can't remember where the heck I am. So, all right, Len, I'll give you a buzz in about 10 minutes, 5 to 10 minutes. And everybody else, have a good week. Think about PCRI. It's really worth coming out, as Neville will vouch. He's got more PCRI T-shirts than I have for sure. And there's always good things going on. And this year with Chet Teisberg being there and the Mad Professor demonstrating the life-size man-junk project, it will be spectacular. We guarantee it. Okay. All right. Good night, everybody. Oh, and Jake, you'll download and you'll let me know when it's loaded. Yeah.
Yep. I'll put it on Dropbox for you.
Thanks a million. Okay. Good night, everybody.